Hi everyone, my name is Abdul Rehman and I'm a neuroscientist. So you have watched our recent podcast that was on the different topics of neuroscience, psychiatry, and different comparative studies of religious studies. So today we have Dr. Anish Chagpar for a very different topic and a diverse topic that I think needs to be discussed, because in the countries where I'm from, like Pakistan, India, Bangladesh, Sri Lanka, such issues are very they are not discussed much, or there's a taboo of discussing such issues. So today the topic is breast cancer, its causes, treatment, and underlying symptoms. So Dr. Anish Chagpar, she completed her MD with honors in research from University of Alberta, and she also went for her surgery residency and training from University of Saskatchewan. And she also went for doing interdisciplinary breast fellowship at the University of Texas. So she also went on to complete the interdisciplinary breast fellowship at University of Texas, and she also did her master in public health at Harvard Public Health School. Further, she's also working with Medical College in Pakistan, Aga Khan University, in collaboration with the Breast Cancer and Awareness. Thank you, Dr. Anish Chagpar, for joining me today on the podcast.
My pleasure. Thank you for having me.
So I'll start the podcast with the question, like, for my audience, there are several people. There are doctors, researchers, and also the layman. So I want to make it a balanced podcast. Like, so would you tell what's the difference between the normal and the cancerous cells, and how do they or how do they develop the cancerous cell from the normal cells?
Right. So I think the easiest way to understand cancer is simply that the normal cells in our body always replicate, right? They're always growing and dividing. That's part of normal life.
Mm-hmm.
When these processes occur, they occur with a certain regulation. So it's very much like if you're driving down a street, there's regulations. How fast you can drive, when there's a stop sign, you must stop, when there's a green light, you go. And if you disobey the traffic signs, then real problems can happen.
Mm-hmm.
And it's the same thing with cancer. So cancer is when those normal regulations, they cease to exist.
Mm-hmm.
So it's very much like having a car with an accelerator and no brake pedal.
Mm-hmm.
These cells, they grow very rapidly and they divide very rapidly without the normal regulation that cells have. And
Mm-hmm.
so in so doing, they become abnormal.
So can we say that, like, there is less number of the tumor suppressor genes, or there is mutation actually in the BRCA genes in the body, or something like that?
So I think we should take a step back.
Mm-hmm.
And think about a few things, because there's a couple of things that you mentioned there, and I think that it's important for our audience to really be clear on some of the issues. So when we think about cancer and the genetic underpinnings of cancer, what causes cancers to go haywire? What causes this regulation not to be there?
Mm-hmm.
Sometimes that is due to an absence of a tumor suppressor gene, that is to say, a gene that normally is there to prevent you from developing cancers.
Mm-hmm.
Or it could be that an oncogene is turned on.
Mm-hmm.
So these are genes that we have that normally are silent, but when turned on become cancerous.
Mm-hmm.
BRCA is a different issue a little bit, in the
Mm-hmm.
sense that BRCA is a gene that all of us have, that if
Mm-hmm.
mutated,
Mm-hmm.
can increase your risk of developing breast cancer, ovarian cancer, prostate cancer, pancreatic cancer. But the thing that I wanted to distinguish here is that very few people actually have a BRCA mutation who go on to get breast cancer. So the vast majority of people who get breast cancer, they do not have a BRCA mutation.
Mm-hmm.
In fact, the majority of people who get breast cancer don't even have a family history of breast cancer. So the main risk factors for developing breast cancer are simply being a woman and getting older. These are the two main risk factors.
So I have a question from where you left that when the women get older. But before that, I would like that if you could explain a bit on proto-oncogenes and oncogenes. So what's the difference between them?
Yeah, so proto-oncogenes, as the name implies, is kind of the step before an oncogene.
Hmm.
So how does an oncogene get turned on? Well,
Hmm.
it's activation of a proto-oncogene.
Hmm. So you said that as the women get older, then there's a more risk to breast cancer, right? So can we say that the more they are exposed to the estrogens or the delayed the menstrual cycle goes, and that's the reason for one of the risk factors for the breast cancer.
Yeah, so again, I want to just decouple those two concepts, right? So
Hmm.
age is an independent factor for
Hmm.
developing breast cancer, independent of estrogen exposure. But to
Hmm.
your point, it's true that estrogen exposure is another risk factor. So when you think about estrogen exposure, I like to think about it as endogenous and exogenous. So,
Hmm.
for example, you may be taking exogenous estrogen. So, for example,
Hmm.
some postmenopausal women may be taking exogenous hormone replacement therapy to
Hmm.
overcome menopausal side effects, which then increases their risk of breast cancer. When we think
Hmm.
about endogenous estrogen, that is related to your menstrual cycle. So we know, for example, that people who delay pregnancy,
Hmm.
people who have later onset of their periods, people
Hmm.
who have fewer pregnancies, people who have earlier um, uh, uh, menopause.
Hmm.
These factors can impact your risk of developing breast cancer.
Hmm. So, what's the underlying physiology for that? Like, if people want to understand, or there are young doctors listening, or the researchers, what's the underlying physiology that the more you're exposed to the either endogenous or exogenous estrogen, but how does it becomes a risk factor for the breast cancer?
Yeah. So I think that it depends on how in depth you want to get.
Hmm. Hmm.
But we know, for example, that breast cancer cells, about 80% of breast cancers are estrogen receptor positive. That is to say
Hmm.
that they have a receptor that is responsive to estrogen. And we know that there is an ER pathway. So when that estrogen receptor gets activated, there is a pathway that stimulates these cells to proliferate.
Hmm.
And so that is kind of the underlying mechanism at a cellular level
Hmm.
for estrogen to increase risk. Um, on a more macro level, we know, for example, that estrogen, breasts are hormonally dependent organs, right? And so they, by their nature, will
Hmm.
be more proliferative in an estrogen-rich environment. We know that
Hmm.
breast density is associated with estrogen exposure as well. So there's a myriad of factors that
Hmm.
kind of all go together that link estrogen to breast cancer.
Hmm. You talked about proliferation. So, uh, while I was a graduate student and we were doing some research on cancer, actually breast cancer, so we also read about the vascular endothelial growth factors, right? So, could you also please specify what's the role of those growth factors in breast cancer?
Yeah, so VEGF really is much more of a factor in other kinds of cancers, but has been shown to play a role in some breast cancers. I don't want to exaggerate its role in breast cancer because, truthfully, it's less of a role, for example, than estrogen
Hmm.
receptor. But when we think about vascular endothelial growth factor or VEGF, if you think about any malignancy, right?
Hmm.
Um, cancers often, in order for them to grow, right? When we talked about these cells, they're proliferating, they're growing. Well, in order to do that, they need a blood supply.
Yep.
And in order for them to metastasize and grow other places, they need a blood supply. And so many cancers have developed this capacity to form these blood vessels, this angiogenesis.
Yep.
And as part of that, vascular endothelial growth factor, as the name implies, is implicated in that process.
So, like for the treatment, we will move on to the treatment next, but just like an overview here, like in the treatments, can it be a biomarker for the drugs to target that growth factor to stop the angiogenesis?
Yep, so certainly VEGF inhibitors have been used in a number of malignancies. As I say, it's not so common in breast cancer. Thinking about things like Avastin are not typical agents that are used in standard of care breast cancer, but often can be used in other malignancies and have been looked at in breast cancer, but have not really made it into kind of the standard of care, as opposed to targeting estrogen receptor, which is very much part of standard of care for the treatment of breast cancer.
So for someone who, as I discussed, and you're also working on the project with Aga Khan University, and you know that there are many people and areas in Pakistan, in India, even like underprivileged areas, people don't know, and there are many women who suffer from breast cancer and they don't know. So like I will try to also translate this video with the subtitles in Urdu as well and in Hindi so that people can get benefit from that. So for a person who actually doesn't know anything about the medical terminology or something like that, what would be the symptoms for breast cancer so that people can become aware?
Yeah, so this is a topic that's very near and dear to my heart because I've been very much involved, as you mentioned, in global health and in breast cancer, and this question kind of merges the two. And in fact, I'm giving a talk on exactly this. How do we screen and prevent breast cancer in low resource settings? So I'm going to direct some of your audience over to my YouTube channel as well, which is Chagpar MD. So watch for that video, and I'll send you the link so you can put it in your description box so that everybody can benefit. But essentially, here are a few things that I think we need to keep in mind. So number one is when we think about breast cancer prevention and screening, there are two main things that we need to look at. The first is in terms of prevention, how can you actually primarily prevent getting the disease to begin with, which is different than screening, right? Screening is secondary prevention. How can you pick up the cancer early? But even before that step, how can you prevent it? How can you reduce your risk? And that's where we talked about some of the things earlier, right? About estrogen exposure, for example. So one of the things that people advocate, especially in low resource settings, is something like breastfeeding. Breastfeeding has been found to reduce your risk of developing breast cancer, but it's also a wonderful way to provide immunity to your baby. It's cost effective. It's sterile. There's so many advantages to breastfeeding, for example. So thinking about primary prevention, breastfeeding, maintaining a healthy weight, physical activity, all of these things reduce your risk of developing breast cancer, and all of them are cheap or free. And so why not do that in low resource settings? But to get to your current question about screening, when we think about screening, especially in low resource settings, we think about various categories that have been looked at. So one is self-breast exam, one is clinical breast exam, one is mammography. And the Breast Health Global Initiative, which is an initiative that Ben Anderson has put together out at the Fred Hutch, has really looked at this and has a very nice matrix depending on what kind of a resource setting you're in for what is most effective. Now, we know that in general, self-breast exam has not been found to be terribly effective, even in low-resource settings where you would think that, this would be a tremendous way to downstage cancer. The majority of cancers that are found in low-resource settings, whether it's Pakistan, India, Africa, any low-resource settings, the majority of these cancers are found late in stage 3 and 4 when treatment is difficult and less effective. Whereas, by the grace of God, in Western countries, the majority of our cancers are found in stage 0 or 1. So if we can downstage, that would be helpful. In terms of self-breast exam, when people have looked at actual data, like clinical trials that have been done, it doesn't really seem to be that beneficial. Now, certainly you can't argue against being aware of your body and reporting symptoms to your doctor. But if you actually look at the hard data, the data aren't there. Where the data are there for cost-effective strategies in low-resource settings is in clinical breast exams. So, for example, there was a very nice randomized controlled clinical trial that was done out of India where they trained community health workers to go and do clinical breast exams. So they would actually do a clinical breast exam and found that they could very nicely downstage women with breast cancer. So taking people who would normally be staged at a stage 3 or 4 and moving them to a stage 1 or 2. And that really has a dramatic impact. It is cost effective and really very efficacious. So in low resource settings, that's our primary recommendation. So what are you looking for on a clinical breast exam? You're looking for things like a lump, something that is different than your normal body, right? So you'll know when you feel something that is different, right? It's a little firmer, it's a little less mobile. But if you are concerned about something, you should talk to your doctor. And certainly this is what we train people to look for in terms of clinical breast exam. The second is skin changes, right? So if you have redness of the breast, skin thickening, dimpling, puckering, the nipple starts to invert, or if you have blood coming out of the nipple, these are all things that you should think, oh my gosh, this could be a sign of breast cancer. When we look at other screening modalities like mammography, right? So you and I are both here in the US, where screening mammography is standard, right? Everybody gets a mammogram, or everybody is advised to get a mammogram. But in low resource settings, we know that this is not optimal. Why not? Well, number one is the cost of mammography, right? It's not as cheap. Second is the actual equipment, and then the manpower or the woman power to read that, right? So the lack of expertise. And then there are all of the downstream costs, right? So what happens if you find something on mammography that you can't feel? Well, how do you biopsy that? You can't feel it to biopsy it. So now you need stereotactic equipment. This is additional expense. Okay, so now you have that. But then how will you actually take it out? Because it's in a very localized area. Are you still going to remove the whole breast, right? And so then you'll say, well, then I need localization techniques. But if you do that, then you need radiation. And so there is this spiral of things that you need downstream. So the general recommendations for low resource settings is number one, primary prevention. And number two, secondary prevention or screening with clinical breast exam.
Great. Actually, that was a wonderful explanation, and it was more than the research project I took in my graduate year. So briefly, and my last question, what could be the core receptors or the target areas for the drugs?
Yeah. So I mean, this is the area of much investigation. I will tell you that currently for breast cancer, and this is different across other cancers as well. So for every cancer, remember there are different targets. For breast cancer, the main ones are really estrogen receptor and progesterone receptor, as we talked about, female hormones that are targeted. And these are targeted either with selective estrogen receptor modulators called SERMs, things like tamoxifen, which is very cheap and very effective not only at treating 80% of breast cancers that are fed by estrogen, but also reducing risk, right? Because you're blocking that receptor. And we talked about how estrogen is one of those factors that helps cancers to proliferate. So it also reduces your risk by 50%. So that's one modality. The second is in postmenopausal women, not so much a receptor, a drug that will act on the cancer cell itself, but knowing that for cancers that are estrogen receptor positive and that are fed by estrogen, you can reduce estrogen in postmenopausal women by turning off aromatase. So aromatase is an enzyme that in postmenopausal women will convert androgens into estrogens in peripheral fat. Many women say, you know, I'm postmenopausal, I don't have estrogen. Well, actually you do. It just doesn't come from your ovaries. And so if you block aromatase, you block that conversion to estrogen, you effectively reduce the estrogen levels. So estrogen receptor and progesterone receptor are two main targets. The third main target in breast cancer is a target called HER2. HER2 is a tyrosine kinase receptor. And currently there are two drugs that are used to target HER2. One is trastuzumab, which goes by the trade name of Herceptin, and the other is pertuzumab, which goes by the trade name of Perjeta. And for patients who are HER2 positive, these drugs are incredibly effective. Now, are there other pathways that could be at play? And other targets, of course. So in patients, for example, who are what we call triple negative, they are estrogen receptor negative, progesterone receptor negative, HER2 negative, then what are you going to do, right? Your three main targets are not there. So traditionally, those patients have been treated with standard chemotherapy. Chemotherapy is designed just to block that accelerator, right? So to block that growth process that happens in these cancer cells. But it does that indiscriminately a little bit. So that's why all of your rapidly dividing cells, including your hair, will fail to grow, right? That's why people lose their hair during chemotherapy. But there's a lot of work going on in this area at the moment. So for example, immunotherapy is being looked at in triple negative breast cancer because triple negative breast cancer tends to be more immunogenic. So looking at whether if we looked for PD-1 and PD-L1, whether we could use immunotherapy in triple negative breast cancer is something that clinical trials are currently looking at as well.
Wonderful. Thank you so much, Dr. Anis Chagpar, for all the explanation and for letting my audience know about such an issue. Thank you so much. I'm honored that you joined me on the podcast. Thank you.
My pleasure.